Hello and welcome to this brief video on evidence-based medicine prognosis. This will inform you on how to search for information to answer a prognosis question. This is from the Department of Family Medicine at RCSI Perdana, and I am Professor Anthony Cummins. This is the format of this video. We'll have some learning outcomes, then we'll look at a clinical scenario. We ask why prognosis is important. We look at research study design and prognostic trials, how to approach a prognostic dilemma, and we look at results of cohort studies. Critical appraisal of cohort studies will not be covered in this video, as it's covered in another video and in a class on critical appraisal. These are your learning outcomes. Having reviewed this video, you should be able to write a PICO-structured clinical question about prognosis. You should then be able to outline how to conduct a search of the literature to find a paper to answer this question. You should then be able to appraise this paper and apply it to your patient. Let's look at a clinical scenario first. A 14-year-old boy is brought to your clinic by his mother, who is worried about his increasing weight. You sensitively discuss this with him and his mother, and he agrees to allow you to calculate his BMI, and you find this is 31.5. His mother expressed her concerns that he would continue to remain obese, and this may lead to premature heart disease. And her concerns about this are because of a family history of both obesity and of heart disease in her own family. Two of her brothers had angioplasties in their early 40s. He subsequently wondered about the natural history of teenage obesity, and specifically, does it usually lead on to adult obesity with its potential for a range of health problems, especially given this boy's family history. You conduct a literature search and find a cohort study looking at this issue. The Association of Adolescent Obesity with a Risk of Severe Obesity in Adulthood, published in 2010 in the Journal of the American Medical Association, JAMA. So why is prognosis important? Well, it is a very important factor in patient care and in clinical decision making. Patients frequently ask about prognosis. It provides very valuable information for the future and for family plans. What you need to know as an emerging doctor is what influences the prognosis for my patients. There may be demographic factors, treatment factors. Some treatments are more effective than others, so the prognosis for patients given better treatments may be better. Demographic factors would include their racial background, their social class, and so forth. There may be disease-specific factors also. And when you're assessing prognosis, you should consider when and how often the patient should return for follow-up and monitoring, and what information should be shared with the patient regarding their prognosis. Let's look at research study design. This is a general view of all kinds of studies. And the first question you want to ask when you see a published paper, did the investigator assign an intervention? If they did not, then this is an observational study. If they did, it's an experimental study. And if it's an observational study, was there a comparison group? If no, then this is purely descriptive. And if yes, then it's analytical. You next decide in which direction this study went. For example, were patients exposed to something and then they were followed over some time, usually many years, for an outcome of interest? Or was the outcome already known, and then did you look back retrospectively to see which of those with that outcome of interest were exposed to what you're concerned about? If the exposure and outcome are at the same time, then this is a cross-sectional study. If it's a retrospective study, it's a case control, and if it's an exposure before outcome, it's a cohort study. This would also be described as an inception cohort as it progresses forwards in time, but you may also have retrospective cohort studies. If the investigator did assign an intervention, then this is an experimental study, and then you need to decide whether there was random allocation. And if there was, then this is a randomized controlled trial, and the other one would be a non-randomized controlled trial. So the ones we're looking at here, we're interested in here, are cohort studies, because these are the ones that answer questions about prognosis. How do you structure a question about prognosis? Well, this looks at a cohort or collection of subjects or participants and observes them prospectively over time. It might be exposure to time alone or to a substance or event in order to assess the impact of that exposure on measurements of interest. For example, over time, changes in blood pressure, changes in cholesterol levels in the original cohort in the town of Framingham, Massachusetts, give rise to a whole selection of cohort studies and published papers, which were later used in the derivation of cardiovascular risk charts. There are three main elements to a question on prognosis. There's the population, there's the exposure, and there's the outcomes. So this is not the same as PICO. PICO is to do with therapy questions and randomized controlled trials or systematic reviews of randomized controlled trials, where there's an intervention, there's a comparison group. There is no such intervention here. So the cohort study is conducted by, first of all, recruiting the cohort, and then you measure the exposure at the outset, and you follow up over a period of time, and you calculate the relative risk associated with that exposure. Here's an example of a cohort study. This was a paper published in 1994 in the BMJ on mortality in relation to smoking. It was a 40 years cohort study on male British doctors. This is to compare the hazards of cigarette smoking in men who formed their habits at different periods and the extent of the reduction in risk when cigarette smoking was stopped at different ages. It was a prospective study which began in 1951 and didn't finish ultimately till 2001. There were virtually 35,000 male British doctors involved, and information was obtained about their smoking habits in 1951 and periodically thereafter. Cause-specific mortality was monitored for 50 years. The main outcome measures were overall mortality by smoking habit. And you can see down at the bottom here that among the men born around 1920, prolonged cigarette smoking from early adult life tripled age-specific mortality rates. But if they'd stopped aged 50, this hazard ratio was halved, and cessation at age 30, virtually zero. So this is the original population, and they were compared to those who never smoked, and then death rates were calculated to compare smokers to non-smokers. If you want to click on this link, you will get the original full-text paper. What are the advantages and disadvantages of cohort studies? Well, we've just seen one of the disadvantages just now. Time-consuming. That study on British male GP smoking was extremely time-consuming. So you get no instant results with a cohort study. However, they give very valuable information and can test hypotheses about more than one disease at a time and can determine risk factors for complications or other outcomes. And the incidence of disease is directly measured. So there are no surrogate markers here. You're looking at particular disease or you're looking at dichotomous outcomes such as death. Another disadvantage is that you may need very large sample sizes. So for example, in that previous paper, there was 35,000. Loss to follow-up may introduce bias, particularly loss to follow-up towards the end of the study, where you may have more of a preponderance of disease. And therefore, if people are lost to follow-up at that stage, they can very much bias the results. This is generally the way this is a typical 4 A's of evidence-based medicine. Ask, but ask in a structured way by converting your query into a structured PICO style question. You then access the evidence through searching through various databases and other sources. You then appraise critically the evidence that you've received from these published papers in terms of validity, results, and applicability, and then you decide if it is applicable to your patient. There's sometimes mention made of another A here, the fifth A, which is to do with audit, so that having done all of this, you would then periodically, maybe annually, re-audit how you are doing with this and see if you need to make further changes. Here are some references for you. The main reference is the Centre for Evidence-Based Medicine at Oxford. They have some very useful tools for helping you to do critical appraisal. PubMed for handheld, which we've discussed previously, and also in our own RCSI Perdana library, you get access to all of these. And we will go through with Mr. Hasbullah, the senior librarian, how to search Cochrane Library, how to search PubMed, Dynamed, and UpToDate. Thank you.